Hello, this is Dr. Paul Cottrell, and we are recording this on June 1st. I'm going to be putting this video up on YouTube, Brighteon, Bitchute, and Rumble. Make sure you subscribe to all my channels. I have 7 channels. I have 4 channels on YouTube, Brighteon, Bitchute, and Rumble. All right. So please subscribe, get the notifications, make sure you follow me on X or GETTR, and share the links. Ask your social media to follow me. I greatly appreciate it. If you liked it, the content that I do and you'd like to help support my work, take a look at my website, the-studio-reykjavik.com. I have lots of different products there. We'll talk about the products in a different video. But because of the censorship in YouTube, I can't say certain things. All right. So make sure you listen to the other videos I do, especially the one right after this one, so you understand what you need to do. All right. There is ways to mitigate these problems. Now, please also, if you like to help support the content, donate. You can donate through Stripe, PayPal, or buy me a coffee on my website, the-studio-reykjavik.com. You can also be a paid member to my Patreon channel. I do these videos for free, all right? It informs the public on how to take charge of your health and understand the realities of a situation. If you have cognitive dissonance, you're not going to like what I have to say. If you believe in false hope, you're not going to like what I have to say. If you want a big dose of reality, so you know what you're dealing with, then you're actually going to like what I have to say. And even if you don't like what I have to say, if you listen to me, you pay attention to me, you will be able to mitigate the risks. But there is no magic bullet. If you believe in a magic bullet, guess what? It doesn't exist. All right. To set the stage here, cases are starting to go up in Asia. Cases are just starting to emerge in the United States with these new variants. There's a problematic one called NB1.8.1. And these are Omicron variants. Australia's having a problem. China's having a problem. India is having a problem. Hong Kong. All right. So different countries are starting to see this issue. Now, at the societal level, let's step back and look at the big picture here for a second. We're going to go over a bunch of videos too, but let's look at the big picture here. At the societal level, there's lots of antibodies through natural infection and through inoculations. So this is going to be muted in terms of infectivity and transmittability, all right? But there's this concept where something can happen with the mutations where it's easy to transmit, all right? But there's also times where mutations can lead to infecting the cell or infecting the tissues, but the transmittability isn't as well. Or you may have a case where both happen. Or you could have a case where transmittability goes down and infectivity goes down. And there's an attenuation, a full attenuation, right? So there's these different potentialities. Let's repeat. You can have mutations that could lead to less infectivity, less transmissibility, right? You can have mutations where the infectivity increases and the transmissibility decreases. You can have the transmissibility increase and the infectivity go down. Or you can have both. Infectivity and transmissibility goes up. All right, so keep that in mind. So as we go through these different variants that start to attenuate and they die out, and there's selection pressure because of ones that have more infectivity or more virulence, all right, they start to pop up. So we're going to see these waves during the endemic phase of this, and it's going to be with us for the rest of our lives. All right, this is going to be around for a long time. All right, hundreds of years. It's not going to die out. So there's going to be seasonal. And in most cases, it's going to be mild. But you're going to have people that where their health starts to decline just because of age or some sort of disease state that's unrelated, that could be problematic, a comorbidity that could push them over the edge and have severe infection or death. There's also cases where because of a waxing, because of a waning immune system, because of a waning immune system, you start having increased cases. Okay. So if someone asked Dr. Paul Cottrell, could you get cancer from SARS-CoV-2 virus? The answer is yes. Why? The answer to that question is because there are proteins, plural, proteins, that are tumor suppressors, including the spike protein. Spike protein can inhibit P53, but there are other proteins that are actually tumor suppressors. In addition, it can cause damage to the cell that can lead to certain fusion proteins that are associated with cancers. I've done different videos on the subject matter, so you can search through. I believe I published those in 2022, 2023. I think it was 2022. Now, so the virus can cause cancer, but that doesn't mean everyone that gets the virus gets cancer. So if you get SARS-CoV-2, the virus, you can have tumor suppressors that are inhibited that can lead to cancer. You need normally almost like a 5 knockout in most tissues, about 5 knockout system. 5 things have to not be knocked out to turn cancerous in most cases. All right. In some tissues, in humans, 3 knockouts are enough. Now, in other animal models, 3 knockouts are sufficient. But in most cases, you need 5 knockouts. So you could have tumor suppressors that are inhibited and not get cancer. Now, now you can have other people that have that don't have pre-cancer and get SARS-CoV-2, and those individuals could end up getting cancer. Now, how? Because you have multiple proteins that attack multiple pathways of tumor suppression. So if you're turning off those tumor suppressors, you're inhibiting those tumor suppressors, you actually are accelerating cancer. Now, if someone has a predisposition, maybe 1 or 2 knockouts before they get the infection, before they get SARS-CoV-2, it's just pushing them over the edge faster. Now, there are cases where you have cancer already, maybe in a very nascent stage, and accelerates the process because it already has the knockouts and it's further inhibiting the tumor suppressors. Now, that's just the virus, okay? And that's just the proteins turning off those tumor suppressors or causing fusion proteins. You can have integration of the actual genome of SARS-CoV-2 into your body, into your cells, into your genome, all right? All right. Now, when that happens, that could go into an area where if it is expressed in that cell regularly, then you're producing more of these proteins. So you're increasing the chances of these tumor suppressor inhibitors to be activated, right? Because you have the genome of the virus in our own cells now. So there's what happens is there's a reverse transcription and it integrates that takes place. This can happen in a cell, but it's under certain conditions. It's usually a very stressful, high inflammatory kind of situation. It's rare, but it can happen. All right. So the virus can integrate into your genome. Rare, but can happen. And if it's in an area that is expressed regularly, you're producing tumor suppressor inhibitors in that cell that could lead to cancer. That's one way. Another way is that it gets integrated in and it disrupts. It gets integrated into a tumor suppressor region. And because of that, it's in effect, it basically turned off that integrated gene that used to be a tumor suppressor. You could have also cases where it causes disruption with other genes that are associated with tumor suppressors, like cofactors and stuff like this. So keeps in mind this matrix that we're building up in our head here. You get the infection and it can cause cancer. How? The actual proteins of the virus, even if there's no genomic integration, turn off tumor suppressors. You can have, in rare cases, where the actual genome of the virus is integrated in your cells, integrated in your genome of your cells. And in those cases, depending on where that integration is, depends on what sort of problems may arise. You may have fusion proteins, you may have turning off of tumor suppressors, an overexpression of the actual viral proteins that could lead to cancers. Now, that's just the virus, all right? And depending on if you already have knockouts, like a precancerous cell, not a series of knockouts, getting SARS-CoV-2 could accelerate the cancer formation. If you already have cancers, but if you already have a cancerous cell and it has these signals to turn off further tumor suppressors, it's going to accelerate the cancer. So those are some of the ways that SARS-CoV-2 can cause cancer. Now, what about the inoculation? The inoculation, similar, but a little bit different. You can get cancers from the inoculation. And that inoculation, because it's producing the S1 and S2 subunit, which is the spike protein, and the spike protein is a tumor suppressor inhibitor, all right? It inhibits P53. Overexpression of it in certain cells could lead to cancer. Now, if you're just inhibiting P53, most likely, and the cell is non-cancerous, doesn't have any knockouts, chances are that cell will not go cancerous. It will have some disruption in cellular function, but it's not going to turn cancerous. But if you have some other knockouts that take place, then you are going to increase your chances of cancer. That's just with the production of the S1 and S2 subunit, which it doesn't matter which vaccine or inoculation that you received, because it's producing S1 and S2 subunit. Then there's some additional issues that could happen with the messenger RNA. The messenger RNA production has these plasmids, and they can't be fully filtered out. And not only that, I think Pfizer purposely had them in there to help with the efficacy, quote, the efficacy of eliciting an immune response, because their method of PEG 2000 production was less robust compared to Moderna, and their manufacturing of the vaccine was problematic. And to meet the production numbers, I think they cut corners in terms of filtration. So you have these plasmid vectors in the vaccine that could get integrated into your genome, producing lots of spike. By integrating into the genome, it's similar, but not exact, similar to the problems that we have with integration from the virus. Now, integration with the virus is harder. It's a more rare situation because lots of different cellular rarities have to take place to allow human line 1 to do this integration and reverse transcription. All right. But for the plasmid, it's easier. It's not, I wouldn't say common, but it's easier to integrate. And with this SV40 plasmid promoter, it's a common promoter. So if it gets integrated in, then it's going to express these spikes, and these spikes will lead to being able to turn off your tumor suppressors, because the S1, S2 subunits are a tumor suppressor inhibitor. So it increases the chances of cancers through that integration through the SV40 integration. You also could have a reverse transcription of that messenger RNA and integrated into the genome. And in those cases, you'd have the same problem. If it gets activated, if it gets expressed, then you're producing more spike, which leads to tumor suppressor inhibitor. Now, if you have that integration either through SV40 or through the reverse transcription of the messenger RNA in your cell, then what's going to happen is that you could have that integrated in an area that disrupts a tumor suppressor gene. Also could cause cancer. If it goes into a region where it disrupts cofactors for tumor suppressors, then you're disrupting the production of tumor suppressors, which leads to potentially cancer. Now, that doesn't mean just because you have integration, you'll get cancer. But the thing is it's increasing the risks. So if you already have cells that are, or tissues that are already in a precancerous kind of phase with 1 or 2 knockouts already, then you are pushing that individual closer to having cancers. If you already have cancer and having these things happen, then it's accelerating. So you can get cancer from SARS-CoV-2 and through the vaccine. Now, if you have both of them, vaccine and SARS-CoV-2, if you have the inoculation and SARS-CoV-2, then you're increasing the probability of these things happening versus just having one or the other. But it can happen. That's the point. That's the main point that's the main point here. You can get the cancers, you can turn off your tumor suppressors through the vaccine and through the virus. Doesn't mean that's going to happen to everybody, but there's going to be enough people that have been infected, have been inoculated, where you're going to see significance in increases in cancers and in the speed of those growths. Now, there's this other issue that's taking place with SARS-CoV-2 and inoculations, and that is neural issues, neural problems. Now, this is going to be a growing topic of discussion. So there's 2 main problems that I see with SARS-CoV-2 and the inoculations: immune issue and neural issue. Okay, the immune issue, shutting down the immune system. The S1 subunit can basically cause CD4 positive cells to be ineffective. So your CD count is the same, right. Your CD count is normal, but the effectiveness of the CD4s are diminished. Because what happens is the S1 subunit is attaching to the TCR, the T cell receptor. in activating a pro-inflammatory response and not being able to fully engage with the MHC2. So you have that issue. You get that from the vaccine or the virus because the S1 subunit is part of the spike. So it's a vaccine issue or a viral issue. Plus the pulsing. If you pulse, if someone is chronically getting sick, if you've had SARS-CoV-2 or boosters, or possibly and boosters, then what's happening is that you're pulsing your body and it's activating the immune system. And then the immune system has a negative feedback loop through the IgG4, which will lead to tumor suppression, which would lead to immune suppression. All right. So you want the IgG4 to go down, your titers to slowly go down, and then your immune system is healing. But when you're getting pulsed with SARS-CoV-2 or pulsed with the vaccine or both, what will happen is you keep on eliciting a response with the immune system, it becomes non-responsive for extra titers. And what happens is your IgG4 start to go up and it's immunosuppressive. So you don't want that, right? So that's one issue with the immune problem. There's other issues with the immune problem where you're actually disrupting the way the configuration of recombining that takes place to produce antibodies with SARS-CoV-2, all right? It can disrupt that process. Now, some of that is short-term, transient, but if it's affecting the upstream cells that are in your bone, then it's going to affect longer term. But if it's affecting cells that are not upstream but more downstream, then it's more transient. So that's one issue with the immune system. It's what I call AIDS-like syndrome. But that's just with that could be with the inoculation or with the actual virus. Now let's transition to what's happening with neurons and neurological function. And I'll do another video on this because we need to do a deep dive on what's going on here. There are too many people out there that are saying, oh, it's going to be prion disease. Well, no, there's a nuance. And most people don't understand the nuance. There will be cases, and it's happening already, where you're going to have neurological problems through the vaccine, through the inoculation. I should stop saying vaccine. It's a button pushing word on YouTube. The inoculation and the virus can cause problems with neurological function, different categories. All right, but there's some main buckets that I think are really important to take a look at. And further research is needing to dive into this. We're just skimming the surface here. All right, but I'll need to do a different video to really do a deep dive because it's going to take hours to really go over this subject matter. But there are these different categories. One category is amyloidosis. And amyloidosis is a catch-all with where you have proteins that can aggregate. Some of these types of diseases would be dementia, Alzheimer's type diseases. Other diseases are like prion disease. So just because someone has amyloidosis doesn't mean they have prion. But if you have prion disease, it is amyloidosis, right? It's an amyloidosis disease. But just because you have amyloidosis doesn't mean you have prion disease. That's a key distinction that most layman people do not understand, and even most scientists do not understand. All right, so just keep that in mind. So there's these different buckets, and a lot of this neurological problem that's taking place during the COVID era, through vaccines, through inoculations, through the virus, is caused by an accumulation of protein that is not folded correctly. Now, how can that happen? Many different things could happen. The actual proteolytic enzymes could be shut down and it's not breaking up proteins. There could be chronic stress within the cells in the surrounding tissue, in the interstitial tissue, that cause these aggregates to take place. Disruptions in the gene, leading to disruptions with the gene or the actual translation, which leads to the misfolding of these proteins. So you can have a gene that's just fine, all right? And it's creating RNA and creating protein. But if there is a lot of stress, lots of free radicals, lots of inflammation that's going on, there's pro-inflammatory inflammation in the interstitial tissue and even in the neuron, then what could happen is that there is this misfolding of these proteins. And if these misfoldings of these proteins start to aggregate and aren't cleared or cleared slowly, then it could lead to dysfunction of the actual neuron. Another issue could be totally independent of amyloidosis, and that is chronic inflammation leading to the erosion of the myelin sheath, or an overactivation of your glia cells that are eating up some of this brain tissue, all right, in the myelin sheath and all this, all right? So there is this category that it's important to keep in mind, that inflammation through the inoculation, inflammation through the actual virus. Now, the virus can get through the blood-brain barrier, or it can get through by climbing up the axon of the neuron, all right, especially if the entry point is through your nose. So the olfactory pathway, all right, so you got these different ways that it can get into a neuron. But the key is to keep in mind these different categories. Inflammation is a cause. Genomic disruption is a potential cause. Turning off proteolytic enzymes is a cause, all right? And proteins within the virus, or the spike protein within the inoculation, can inhibit some of these processes to be able to clear misfolded proteins or cause an inflammatory response that leads to misfolded proteins, okay? Now, just because you have a misfolded protein doesn't mean you have a prion. But if you start to have these aggregates that start to build up, then you're going to start having misfiring of the neurons, thinking will start to decline, and you start having problems. Another category to keep in mind is vascular. Because of the clotting issue, because of the inflammation issue, you can have cerebrally microbleeding. Now, through microbleeding, that means that you're slowly killing off certain tissues in the brain with these microbleeds. You can also have microclotting, which is ischemic, that's leading to death of that tissue, death of those neurons, and over time, loss of function. So when you're looking at cerebral issues, brain issues because of the COVID era, you got to keep it in mind in these categories. Just because there is a brain problem, a brain, the pathophysiology of the COVID era dealing with the brain doesn't mean it's prion disease. That's just a fact, all right? Now, there's these different probabilities for a patient if they go down this road. You have some that will have an accumulation of proteins that would fall in the category of prion. Very, very, very rare. You have more probability, a much higher probability of getting turbo cancer than getting prion disease. But what you do have is you can have amyloidosis. And amyloidosis is a higher probability than prion disease. Prion disease is less than 1% chance of getting. Probably 0.5%, less than 0.5%. But it could happen. But a lot of things would have to be taking place. And because it's so rare, we're not even sure if it's just associative or causal, right? But it's super rare. So less than 0.5%. But it could happen. Amyloidosis is more common, and that in the patients that are going to have neurological problems, you're probably going to see in the amyloidosis cases around 20 to 25%. So let's just say 25% of the brain disorders that are associated with SARS-CoV-2 or inoculations. You're talking about 25%. But that doesn't mean everybody that gets an inoculation or everybody that gets SARS-CoV-2 will have a brain disorder. Not everybody will have that. But if you do get it, 25% chance of those cohorts would most likely have regular amyloidosis, where it's an accumulation of these plaque proteins. But it's not prion disease, because with the prion disease, you could take out that prion, put it into someone else, and it would infect. But but not a lot of research has been done on prion disease in general, let alone on SARS-CoV-2. So, that's kind of a black hole world of research. But it's very rare, okay? But the manifestations clinically are similar, where you may see an accelerated process of neural decline with prion disease or with amyloidosis, accelerated amyloidosis. And so just keep in mind, prion disease is a subset of amyloidosis. You could have amyloidosis and not prion disease, right? Very key distinction that most scientists and laymen get wrong. Okay, now we have the accumulation of the plaque. We have the potential prion disease. So prion disease about less than 0.5%, probably less than 0.1%. All right, but let's just make it simple for our brains. Less than 0.5%. About 25% approximately would be regular amyloidosis, an accumulation of these plaques. It's similar to what we would call Alzheimer's. Now, the next group, which is approximately 75%, is what will be called mixed dementia. Okay, and there is going to be, that this is most of the cases, that if the patient goes down this neurological path, most cases are going to fall into this category. And that's where you have inflammation that's causing disruption of the vascular system that leads to microbleeding, so a hemorrhage, microhemorrhage that leads to tissue death, or microclotting but both of them are ischemic. So it's an ischemic issue. It's a blood issue, not necessarily a neurological issue. It's a neurological issue secondarily to a vascular issue. So now in this world of 75% of the patients that have this issue, neurological issue from SARS-CoV-2 or from the inoculation, 75% of them are going to have this, fall into this category of a dementia that's caused by microbleeding or microclotting. Now, what causes the microbleeding or microclotting? Inflammation at the vascular level that leads to leakage. Now, that could be in the vascular system or around the vascular system, the interstitium that leads to a tear. All right, so keeping inflammation down is really important. But when you're in a chronic inflammatory stage, you also have lots of free radicals that are starting to be produced. And when you start to have these free radicals that are starting to be produced, you can also cause an acceleration of plaque, all right, because LDL would be oxidized. And it's been known that this clotting is becoming an issue. Now, there's probably multiple mechanisms on why this is happening. Some of it is where your blood cells are starting to attach to each other, attract each other, and stick together. And there is this overclotting, probably through the CD147 pathway. But there is this situation where the red blood cells are sticking together and causing these microclots. Another is that you can have an overabundance of inflammation in a region where you there is this turbulence. You know, sometimes vessels can kind of fluctuate. They can get small and then large again, small. They can kind of pulse, right? And so when they're pulsing, they may cause, a little bit of a turbulent flow, and that turbulent flow can lead to clots. All right, clot formation, microclotting. When you have these microclots that are happening regularly and they're not being dissolved, normally when you have a clot, your body recognizes it and it's going to create chemicals that will lead to breaking up that clot naturally. So we have fibrinolytic enzymes that will break up clots. All right, but if you're having a problem breaking up those clots because of the way the clot's formed, maybe there is a polymerization that's taking place where our natural enzymes are having a hard time to break up these clots, then you will accumulate these microclots, and more of these individuals will start to have neural death, or the tissues will start to decline. So I think that majority of the cases that are neurological issues from SARS-CoV-2 or the inoculation is due to microhemorrhaging or microclotting that will lead to neural death or neurological dysfunction. So you got these three, you got these different categories. You have amyloidosis, but not all amyloidosis is equal. You have a very small subset that is prion disease, very small subset. Then you have a decent amount, 25%, because of that inflammatory response, because of damage to clearing the misfolded proteins, an accumulation of misfolded proteins that will lead to amyloidosis and something very similar to Alzheimer's or Lewy body dementia. So you have this accumulation of problems that are in the neuron, this pro-inflammatory response, and a buildup of free radicals will lead to the destruction of the myelin sheath. So the electrical transmission starts to degrade. So your thinking starts to go down and you start to have problems with memory. And then depending on what area of the tissue of your brain is being destroyed, depends on what your neurological function problem may be. It may be hearing, or it may be speech, or it may be motor coordination. It just depends on where it may be spatial recognition. You just don't know. It just depends on where this problem is. It could be anywhere. So now if someone says, well, okay, this is happening, is it by the virus or by the inoculation? Both. Now someone would ask, well, why? Okay, so you can have inflammation, an accumulation of inflammation from viral infection, or you can have it from the inoculation. There's this inflammatory response that's taking place in the brain, in the brain tissue, around the neurons. All right. Now, you can also have this integration issue problem that I said earlier, where you have the virus that could be integrated in the genome of the neuron, or you could have the actual inoculation messenger RNA be integrated into the neuron. The SV40 could get integrated in the plasmid, or just the messenger RNA could be reverse transcribed and then integrated. And that's rare, and it's got some issues with it. But the thing is, it could happen if it gets integrated in an area that causes disruption with clearing proteins, all right, that are misfolded. Then you're going to have an accumulation of plaque of these proteins and have amyloidosis. This could also happen in other tissues. Amyloidosis post-infection from SARS-CoV-2 has been shown in autopsies and in histology studies where you have it in different organs. So amyloidosis, the accumulation of these plaques, isn't just in the brain. It's in the heart, it's in the liver, it's in the spleen, it's in the kidney. So it's all over your body, right? A lot of people don't realize that. And that's the reason why I said that you have to keep in mind amyloidosis has a lot of different subcategories. Prion disease is one of those subcategories. It's rare. So people have focused on just that because it sounds weird, mad cow disease and all that, right? But there are more of the patients that are going to have brain function issues. Most of them are either going to be accumulation of plaque, regular amyloidosis, or vascular dementia. Those are, so almost 100% of the cases are of those two categories. And a very, 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 very few would be falling into the realm of prion. Now, people would say, well, there's a prion motif and blah, blah. There's more prion motifs for P53 than there is for SARS-CoV-2 spike protein, right? So just because there's a motif doesn't mean it. It's about being able to clear your misfolded proteins. Now, what causes some of these misfolded proteins is mutations that lead to beta sheets from sticking together. When there's lots of beta sheets, then they can come together and it's very hard for enzymes to break them apart. So it's through mutation, but also misfolding in such a way where they can accumulate and misfold and attach to each other, these beta sheets, and then stick. And then it can accumulate over time. So, there's some enzymes that, well, if you have a misfolded protein and you have a few beta sheets in that protein, maybe it can be broken apart. But if you have, let's say, a misfolding of the protein, the beta sheets are connecting in that protein, and then other proteins are misfolded, those beta sheets of the other proteins start to accumulate and stack like pancakes. Well, if they're stacking like pancakes, it's much harder for the enzyme to come in and break it apart. So it depends on how many beta sheets, folds are taking place within a protein and how many of those are accumulating with subsequent protein misfolds. So there's this, is it a two proteins aggregate? Is it a 5 protein aggregate? Is it an 8 protein aggregate? Those are big differences in terms of the ability to clear it. So if you have integration that's taking place from the inoculation, either through reverse transcription of the messenger RNA or through the actual integration of the SV40 plasmid, you're going to not be able to clear these aggregates as well, and you're going to lead to amyloidosis. But potentially, some of those cases may lead to prion disease, but those are super rare. Like I said, you want to use the 80-20 rule, right? You're looking at a problem. What's 80% of the issue? Oh, once you solve that, then you start working on 20% and go out of that 20%, what's 80% of the issue? And if you just keep on working that through, then you solve the problem. All right. So if people are just focused on prion disease and SARS-CoV-2, you're missing the boat here, because almost 100%, just under 99.9% of the issues with brain function during the COVID era, because of the virus or the inoculation, is through vascular dementia or through regular amyloidosis. So people need to pay attention here, okay? So you can have you can have brain function problems, brain pathophysiology issues, all right, because of SARS-CoV-2 or the inoculation. Now, parts of it are because of inflammation. Parts of it could be from integration. Parts of it could be disrupting the ability to clear misfolded proteins, because the more stress a cell is in, the more proteins will be misfolded. But there's a feedback that as long as those proteolytic enzymes are functioning, you can break up the protein. Well, if those mechanisms are not working right, those enzymes aren't working right, or the vesicles that are within the cell to be able to help break up that protein aren't working right or hijacked, then you're going to have protein accumulation. You're going to have these amyloidosis. And this is the reason why many other organs have amyloidosis post-COVID infection, post-SARS-CoV-2 infection. All right, so just keep that in mind, right? So if you're a person that thinks, well, if you took the inoculation, you're fine, wrong. You're not fine, because some of these things can happen either with the shutdown of your immune system, the integration, or issues with at the cells and the tissue level for causing turbo cancer, or problems with your brain function. And that brain function with that inoculation could be over inflammation that leads to myelin sheath destruction, could lead to integration or disruption of proteolytic enzymes, or lead to that inflammatory response will lead to that misfolding of proteins and an accumulation of amyloidosis, these amyloid plaques. All right. If people are saying, well, it's only the virus, or if people, let me rephrase that. If people are saying, like I said, just a few seconds ago, if people said, well, they took the vaccine and they're fine, no, things can happen. If people say, well, they didn't take the vaccine and things are fine, well, no, that's not true either, because you can have these problems with the virus too. It's different, especially with the SV40 plasmid, is in the inoculation, not with SARS-CoV-2. But integration can happen. It's less prevalent, but it can happen. Also, you have more proteins. You don't have just the spike protein, you have more proteins. And those proteins are tumor suppressors that are in SARS-CoV-2. or can cause an increase in fusion proteins. All right. And that will lead to cancers. Or if with the virus, it can get into the neuron and cause disruption at the genomic level that turns off proteolytic enzymes or causes misfoldings or mutations with those proteins and an accumulation of amyloidosis or inflammation that's taking place because the cell's stressed and the myelin sheath starts to degrade. So lots of things can happen here. Now, not everybody is going to get brain dysfunction because of SARS-CoV-2 or inoculation. But the ones that do, they fall into these different categories. Vascular dementia, amyloidosis, and a subcategory, prion, and that's extremely rare, less than 0.1%. All right. And you have 75% that's more on the vascular dementia category. That's microbleeding and microclotting problems. And then about 25% are amyloidosis. All right, that's a long-winded of saying SARS-CoV-2 can cause cancer and brain dysfunction. The inoculation can cause cancer and brain dysfunction, but not everybody will have it. Hope that makes it very clear. Now, if people say, if you get the inoculation, you're going to get prions, wrong. If you get SARS-CoV-2, you're going to get brain dysfunction or prion disease, wrong. It's rare. But it can happen. You're more likely to get some sort of dementia that's accelerated because of microclotting and microbleeding or microbleeding. And what makes it even more complicated is that people that get older, they already have maybe a little bit of a buildup of plaque, a little bit of amyloidosis, a little bit of Alzheimer's that's starting to develop. And then they start having the vascular dementia on top of it and accelerates it. So normally when you have someone that is an Alzheimer's patient, they slowly decline. It's like a 10-year or more decline. Vascular issues is a rapid decline. Prion disease, typically, there's a couple different categories, typically is rapid. All right, within less than a year, it's about 6 months. But there are rare, very rare prion disease. Prion disease is rare. Then you have rare of rare. So, and within the category of prion disease, the ones that are even rarer, the rare versions are long lasting, like, or that happen over a 5 to 8 year period. They're very, very, very rare. All right. Now, part of that rareness, maybe we don't know enough about the disease. That could be part of it because it's so hard to capture that data. Another part of it is that it truly is rare. All right. Now, again, go back to the 80-20 rule. Focus on where most of the problem is. Amyloidosis, which is about 25% of the cases that fall into this category of neurological dysfunction, and the 75% that is vascular dementia. All right. That's where the focus should be on. Don't focus on the 0.1%. Yeah, it's, it's titillating, it does great headlines, but that's not what's really going on. All right. So if you already are on the path of dementia, Lewy body, Alzheimer's, some people, part of the present clinic presentation, even with Parkinson's. All right, if you start having these neurological dysfunctions already and you get SARS-CoV-2 and or the inoculation, it may accelerate your neurological decline. All right. Now, with the Duck Dynasty guy, I think his name's Roberts Phyllis, something, Filson or something like that. He passed away relatively quick. Now, we don't really know what his particular issue was, but what it is known in the public domain is that he had dementia, and he had a blood disorder. That's how he phrased it. Now, he may have had a blood cancer, and that led to clotting issues. And if it led to clotting issues, you would have accelerated the dementia because of the microclotting that could be taking place. And it was accelerated because he already had dementia. He already had Alzheimer's. Some people would say, well, maybe it's prion disease and he had it, maybe because we don't know if he was inoculated or if he contracted SARS-CoV-2. To my understanding, we don't know that in the public domain. But I suspect that the rapid decline that he had was due to vascular dementia, that something was going on with microclotting, and that he may have already had Alzheimer's. Now, it could be that this was, because what happens usually is that the microclotting, it may happen and it's not even symptomatic. You don't see any problem. Then all of a sudden you slightly lose your memory, or slightly lose speech, or slightly lose some sort of brain function. And then over time it starts to accelerate. And the brain, the brain death, the tissue death starts to accelerate. And so it's more prevalent. And it could have been that this whole thing that he had was actually through the microbleeding because of the problems with his blood. I suspect that he had probably some sort of overproduction of blood cells. And when it's overproducing the blood cells, then it leads to clots. He also had lots of pain, and he also had problems with his spleen. So that's signaling that there was an overproduction of blood cells. So that's my take on it. All right. Not prion disease. Prion disease doesn't give you pain in your in your kidneys or in your spleen. All right. But again, there's not a lot of research on prion disease. But that gives you a really good overview. SARS-CoV-2 can cause cancers, but not always. And the inoculation can cause cancers, but not always. SARS-CoV-2 can cause brain dysfunction. Not always, but it can. And the inoculations can cause brain dysfunction, but not always. Okay? So those are the facts. Now let's go to what's going on with SARS-CoV-2. All right?
I see infinite possibilities with flow.
What manner of magic is that?
The World Health Organization says it is monitoring a new COVID-19 variant that's been spreading in Asia and leading to a spike in hospitalizations in China. Now, this new strain has also been detected in the US. For more on this, I'm joined by Deakin University Chair in Epidemiology, Professor Catherine Bennett. Good to have you on the program with us, Catherine. Now, this new strain of COVID, it's called NB181. It's been responsible, as I mentioned, for a spike in hospitalizations in China and now even the US. What do we know about this new strain?
Well, it's been around since early in the year, since about January it was first reported, but it has seen a rise not just in China but in Asia. It's actually spreading through most countries now, and it's been in Australia since last month as well. We had a pretty mild last wave.
So even if you have mild, pulsing with either overboosting or getting a infection, when it's repeated, you're increasing the probability of the problems with turbocancers and neurological dysfunction.
In the Northern Hemisphere, the winter wave wasn't as severe. And so we might have got away with that. Certainly with us, our summer wave really didn't have the same impact. This variant is still related to the same family of variants, the JN1 that we saw driving some of that infection in our winter wave and then through the end of the year. But it's a new variant. And the reason they're watching it closely, the World Health Organization's deemed it to be a variant under monitoring, is because it has this combination. It's able to evade our immune response because it's a bit different. It's got these new mutations, but also it looks like a strain that's particularly good at latching on to the receptors in our respiratory symptoms. So if it's going to cause more infections and it's easily spread, those two things actually mean we have to watch out for it, and particularly as we go into winter. The symptoms, the disease doesn't look to be more serious, but if you get a lot more infections, we could see more people very unwell. And that's why the booster is going to be very important for us going into winter, particularly for people still at risk of severe disease.
Yes, if it does, as you say, evade immune responses, should the general public be somewhat concerned, as well as health authorities in Australia?
Well, they'll keep a close watch on it. We'll watch what's happening in the countries where it's spread earlier. We've already seen it in New South Wales. It's being detected in the sewage water in Western Australia, and it's now the most common variant. So we're already experiencing it, and they'll watch it closely. The good news is that it's descended from the JN1 variant, and that's what our vaccine is based on at the moment. So the vaccine isn't a perfect fit because the virus has moved on again, but it still works to particularly prevent against severe disease. And that's the most important thing. We want to keep people out of hospital if we can, particularly if the infection rates start to really pick up over the winter period.
Yeah, yes, I mean, you did say that we possibly had it easy in the last wave. Would you expect that things might be different when winter arrives?
Well, we always worry that a winter wave could be worse just because we spend more time indoors, you're socializing indoors more often. All those things, the atmosphere, the humidity, they're things that the virus enjoys, and respiratory infections generally do better in winter for the virus, not for us. So we do worry about the numbers going up over our winter break, and we do want people to be really careful to make sure.
See, amazing, and how all these supposedly experts, epidemiologists, MDs, nurse practitioners, all of them seem to be missing the elephant in the room. That if you continually have infection by SARS-CoV-2 or you overboost, what's going to happen is that you're going to cause an increase in your problems with your immune system, your vascular system, and even brain function. And they're not paying attention to it. They're just so focused on, well, this is going to cause a respiratory infection. That's not the big issue here. The big issue is what I've been talking about from day one, and that is all of these aftershocks that take place after the hospitalizations, after the big waves, after the major infectivity. Because guess what? It takes some time before turbocancer starts to emerge. It takes some time for dementia start to emerge, either through amyloidosis, prion disease, or even some sort of vascular issue. All right, takes time, but it does pop up, and you're starting to see it. If you watch people lately that haven't been reducing inflammation, reducing free radicals, getting healthy, improving their cardiovascular health, boosting up their immune system, the ones that aren't, they're just going back to their pre-COVID lifestyle. guess what? You start watching what they're saying, they're doing a lot of while they're talking. Do you notice that? Or they're having a lapse of concentration in their thought. Now that happens to everybody, especially if they're stressed, all right? But when it's habitual, when someone is doing, let's say, a podcast and they go, all the time, and they used to not do that, problem. I'm noticing it with a lot of newscasters on Bloomberg. I watch a lot of TV because of the show that I do. Is, you know, a 4-hour show, you know, going over markets and breaking news. I'm noticing a lot of individuals being asked to speak as a contributor, or they're newscasters. They're doing a lot of kind of fill in, as if they're kind of losing track of what they're thinking. It's very important. And we'll go pay attention to the next show that I do, the next episode. It's important to bring down that inflammation. It's important to soak up those free radicals. It's important to improve your blood flow. It's important to improve your immune system. When you do this, you're improving your odds of being able to weather the storm. There's no magic bullet. If anyone says there is, they're lying to you. But if someone says, don't worry, they're also lying to you. There are areas of concern. Certain areas of concern have different probabilities, so they're not all equally weighted, and that you can mitigate some of these issues. Now, if you pay attention to what I'm doing, you'll weather the storm much better. You don't, you're increasing your chances of these things to be happening. Now, the experts, supposedly the experts, don't know what they're talking about. They're not paying attention to the emerging properties of a post-COVID era. They're not paying attention to the emerging properties of the aftershock.
They're not, but they're up to date with their vaccines, particularly in Australia. People over 65 are recommended to have an annual shot. People over 75 or anyone immunocompromised and
Don't. Inoculations. Over inoculating is going to, 1, make you non-responsive, and 2, increase your IgG4s. That's immunosuppressive. Increase the chances of genomic integration. Increase the chances of tumor suppressor gene inhibition. So if you're inhibiting a tumor suppressor, you're not inhibiting the tumor, and therefore terminal cancer. All right? Why would you want to do that? The spike protein is a tumor suppressor inhibitor. Wake up. See, when you do serial passage and you're attaching and you're gaining function through many different receptors, you also have secondary and tertiary effects of these proteins that are honing in to be able to survive in an environment. And you're selecting certain properties. And during the serial passage that took place for the gain of function of that spike protein, but also of the different proteins that are in the virus, it gained function on tumor suppressors. It was able to attach to them better and therefore inhibit them. And people need to pay attention to this, that the directed evolution of this, of the serial passage, wasn't just the spike protein. It was the other proteins within the virus. Now, when you get an inoculation, the things that you got to worry about are the S1 and S2 subunit, the integration through reverse transcription of the messenger RNA, or the SV40 plasmids that was used, or other plasmids. My understanding is Moderna used a different type of plasmid, but the problem with just plasmid integration. So plasmid integration, messenger RNA, reverse transcription and integration, and the pathophysiology that the spike protein causes. Those are the things you need to worry about. On top, that's just the vaccine. That's just the inoculation. Now, when you're talking about the virus, now you got gain of function wasn't just on the spike protein. The gain of function was on the other proteins that allowed for tumor suppression. I'm telling you, turbo cancer is caused by both SARS-CoV-2 and or the vaccine. If you just had the virus, well, you have chances of turbo cancer. You also have chances of dementia. Depends on what kind of dementia. Like I said, there's kind of like 3 categories to take a look at this. If you just had the vaccine, you just had the inoculation, well, you've increased your chances of dementia. You've also increased your chances of turbo cancer. You're not, see, this is what I've been saying for 5 years. No matter what path you took, there wasn't a good path. You just pick your poison. Now, again, there are different probabilities of the different ways this can emerge, but there's no safe way. Anyone that thought they were safe, they're just wrong. Well, they're just not going to take it. Well, all right. You get multiple infections of SARS-CoV-2, you're increasing your chances of turbo cancer, 100%. And not only that, you are increasing your chances of turbo cancer probably, if it's once a year and you're getting it once a year, you're probably far worse off than someone that just had 2 shots of the inoculation, assuming no genomic integration. But there's nuance with this. And that's the key thing. I guess that's the key point, is pay attention to the nuance. There's too many people that just say something and then go like, well, wait a minute. Let's use some first principles. Let's use, some logic here. Let's use some, the idea that there are probabilities within this landscape for different patients. And when you start looking at with those kind of perspectives, you start to see what I'm seeing. It's too easy to just say inoculation causes turbo cancer and just, well, there's a nuance there. So does SARS-CoV-2, not just the inoculation. And not everybody's going to have it. And it could just only cause a 1 or 2 knockout, not a 5 knockout. So you may not actually get the cancer. All right. But if you're already near that edge, you could rapidly increase the cancers. Turbo cancers are happening for sure. Lots of people that are younger, post-COVID era, are starting to get problems with their colon at much younger age. Some of that's because of the inoculation. Some of that's because of the SARS-CoV-2 virus. People need to pay attention to what I'm saying. I'm not wrong on this. But like I said, there's no magic bullet, but you can mitigate some of the problems. And if you mitigate some of the problems by soaking up those free radicals, bringing down that inflammation, getting better blood flow, boosting up that immune system, your risk curve starts to go down. But if you don't, you just have maintained that lifestyle that you had pre-COVID, your risk factors for cancers and dementia have gone up.
Also encouraged to have those boosters. So it's good to protect ourselves going into winter with this new variant.
See, this is the problem that they have with immunology. The canonical thought, the dogma, the zeitgeist of it is that just boost up the titers and you'll be fine. It'll neutralize. not realizing that you're actually bringing down your IgG4s. It's immunosuppressive. And by the way, because of the serial passage, the S1 subunit actually attaches the TCR that turns off your CD4 cells so they don't engage to the MHC2. So it doesn't fully activate your immune system. See, they're not paying attention to the serial passage that Barrick and Dr. Shi did. This is way different than the typical viral situation. They're still in their dogma. And this is, you keep on following their advice, and you're raising your risk curve up for further dementia issues, which is a multitude of reasons for that I went over, and cancers. That's not the only issue with SARS-CoV-2 or inoculations. You can also have problems with your heart and your vascular system that's not causing dementia.
Starting to push case numbers up.
Yeah, so as this new strain takes effect and spreads, in the US, we're now seeing that the Trump administration is removing recommendations for pregnant women.
So people would say, well, DrPaulCottrell, what should we do? It's going to harm us either way. The inoculations harm us, the virus harm us. What do you do? Just hide under your bed? No, you live your life, all right? Not everybody is going to have these problems. But the more often you get it, the more often, the higher chance, let's just say, that you are going to manifest some serious problems, either dementia or cancer, or even heart disease. With the myocarditis or endocarditis or even pericarditis. The signaling problems that are taking place with these hearts now, that are taking place. Well, the way you do it is that you need to improve your health. You need to take some lessons learned out of anti-aging. You need to take some lessons learned in geriatric medicine. You need to take lessons learned out of sports medicine. And when you couple these things, you're reducing your risk curve. You're not eliminating it. There's no magic bullet. Everyone is potentially can be affected by this. It's about probabilities. And you want to reduce the probability of these things happening to you. Now, if you're just going to be a germaphobe and live in fear all the rest of your life, well, it's not going to help you. There's no magic bullet. Can't get around from this. But if the labs were shut down before Omicron, we wouldn't have this problem because the number of turbo cancers would go down, the number of dementia cases would go down post-COVID era or the aftershock of the COVID crisis, because less people would have had it. But people didn't listen to me, and therefore we have this problem, and you can't get rid of it now. Because people thought that if you took the inoculation, you'll be fine. And people thought if you didn't take the inoculation, you'd be fine. And I kept on saying, no matter what you did, there was no correct path.
To take a COVID-19 vaccine, are there dangers in this for women who will be having children?
Yes.
Well, we know that the vaccine is safe for women in pregnancy. We know that particularly earlier on when we didn't.
Really? What about the termination of pregnancies early on? What about problems with fertilization? Again, it's the experts are stuck in their dogma. They're not focused. They're just so focused on typical viral type infection dynamics. This is different because it was made in a lab to be lethal. It was serial passed where there was multiple receptors. That means multiple pathophysiologies. And they thought they had a shield for it that just doesn't work. And it was rolled out with poor testing, and it has negative externalities. So you have a shield that has negative externalities, and they had a gain of function on something they should have never have done. And now, for the rest of mankind's life, you know, most likely the rest of mankind's existence, this will be a problem. Thank you, Dr. Barrick, for fucking up mankind.
Good immunity in the population, that actually the vaccine was quite important to help pregnant women get through to a safe end to their pregnancy. In Australia, we don't recommend, but women of any age, 18 and over, are eligible for a vaccine. And if someone's pregnant, we encourage everyone to talk to their doctors. So while it's not recommended for people in that age group who would be pregnant, they are encouraged to talk to their doctor, and they're eligible.
I would not. No. Don't get a booster. And if you haven't had a SARS-CoV-2 vaccine, don't get it. Now, the problem is that you had a lot of healthcare workers that were forced to take it. And not only that, the risk factors for healthcare workers were actually more elevated because they were around patients that had lots of issues. Lots of patients had this problem, right? So if you're a healthcare worker and you're around patients, this is where the average person, the average truther, doesn't understand this issue. When you're not a healthcare worker, you're not usually around people that are really sick, all right? And have infectious diseases of all kinds, all right? So the dogma, the zeitgeist, the paradigm in healthcare is inoculate the healthcare workers so they have some sort of immune protection so they can treat these patients, which seems rational at the surface, right? The problem is that they're over inoculating the healthcare workers who are becoming non-responsive to many of these inoculations, like Hep B, for example, is a perfect example. The same thing's happening with SARS-CoV-2, the COVID-19 inoculation. People are becoming non-responsive. All right, less titers are being, the max titer after a booster is going down, not up. From the max of the previous booster. So it's becoming non-responsive, and it's because of this IgG4 issue. All right, but at least part of it is. So the point here is that the layman thinks, well, healthcare workers did this, and it's and they should have never done it and all this. Well, in most cases they were forced. Some believed in the dogma, so it's not that simple. It's about the nuance. Some people were forced. Some people didn't want to take it. Some of these healthcare workers didn't want to take it. Some of them did want to take it because they believed in the dogma. But their risk factors, the healthcare workers' risk factors in general, were much higher than the average population because of the population that they were surrounded on a daily basis, because they were around people that were sick. So it's about risk assessment. See, it's not so simple to determine, do you take it or don't you take it? If you're in an environment where you have high risk exposure, right? Then what do? If you catch it, you get problems. You catch SARS-CoV-2, you get problems. If you don't catch it, but you take the inoculation, you get problems. Again, there is no good path. But it's too simple for the layman to think, well, I just won't take it. Really? Really? You think it's that simple? Work out the decision matrix. Work out the decision matrix. And no one is safe. No one.
For free vaccine, if that's the right choice for them.
Yes, and just in the US, we are seeing hundreds of people who are still dying every week from COVID. Does it surprise you in any way? Or is this rather the new normal, since the pandemic?
Well, it is a new normal. You know why? Because it's called endemic.
It's hard to say the new normal. So in this administration in America, what we are seeing, unfortunately, is a top-down resistance to vaccination. And so we're getting that message through. I think even the way these recent announcements were made, usually it doesn't come from the Secretary of Health and Human Services. It doesn't, usually
Deakin University chair, children.
Well, we know that the vaccine is safe for when we didn't have good immunity in the population, that actually the vaccine was quite important to help pregnant women get through to a safe end to their pregnancy. In Australia, we don't recommend, but women of any age, 18 and over, are eligible for a vaccine. And if someone's pregnant, we encourage everyone to talk to their doctors. So while it's not recommended for people in that age group who would be pregnant, they are encouraged to talk to their doctor, and they're eligible for free vaccine if that's the right choice.
All right, so now they're going to transition. I had to repeat it for a second because I wanted to make a point about his statement about Trump's administration.
Yes, and just in the US, we are seeing hundreds of people who are still dying every week from COVID. Does it surprise you in any way? Or is this rather the new normal, since the pandemic?
It's hard to say the new normal.
Yes, it isn't. It isn't, quote, a new normal when your reference point is pre-COVID, but that's because of it's endemic. Now the issue is that some people are waking up that there's problems with the testing of these inoculations. It's a big problem. There's lots of money to be made, right? So shining a light on that, but that's a different issue actually. Inoculation testing, in solving that problem and understanding the negative externalities of a vaccine schedule that may be harming people, the elderly or the pediatric. We need to start questioning the actual vaccine scheduling. For sure. But that's a different issue. That's a different issue. This whole SARS-CoV-2 thing is very problematic because of the nefarious things that were going on in laboratories that led to gain of function, that led to inoculation program that wasn't fully tested. And now we're seeing the pathophysiology problems of that gain of function and of that, quote, solution. Now, was there some protection that took place? Some protection for natural infection? Yeah, absolutely. Is there some protection from actually inoculations? Yeah, absolutely. The antibodies have built up in the society. So it slows down that emergent behavior. But my concern is that eventually it will emerge, and in more cases, a bigger wave will come. I suspect that will be in the 10-year mark when you use the reference point from 2020. So I believe in 2030, 2029 or 2030, you're most likely going to see a big wave. Now, will it be as bad as what we saw before? Probably not. There's something going to be emergent out of this. But too many people are stuck in the dogma. It's about nuance. Something really nefarious about what's going on with SARS-CoV-2.
So in this administration in America, what we are seeing, unfortunately, is a top-down resistance to vaccination. And so we're getting that message through. I think even the way these recent announcements were made.
And probably an unintended consequence was that once people start seeing problems that people had with the vaccine injury, the inoculation injury, there was a negative reaction to all inoculations. So everyone is like thinking, well, all inoculations are bad. Well, that's wrong. That's wrong. Not all inoculations are bad. But testing needs to be way better on on these inoculations. That's for sure. And that many people don't understand, even with the inoculations that were okay pre-COVID, in a post-COVID era, they may not be okay because of some weird thing that happens with the body. Now, that's a hypothesis. There needs to be further investigation, but we don't know what the effects of these schedules are for pediatric or for even geriatric. These inoculation schedules in a post-COVID era, what those effects are. We just don't know. I suspect there are effects, but no one's going to test it. No one's going to pay for the money to do these tests. And what will happen is that really weird pathophysiology is going to start to emerge. Diseases will start to emerge. And then the dogma will try to explain it away. And I'm telling you, the two big ones right now are going to be turbocancers, immunosuppression, and dementia.
Usually it doesn't come from the Secretary of Health and Human Services. It doesn't, usually it involves the experts that sit within the CDC over there. They actually have an advisory group on immunisation practice, and we don't know how they've been engaged in these conversations. And we know they've got a problem with measles at the moment. So if we're going to see a rise in these vaccine preventable diseases that are causing severe disease and deaths, sadly, in some situations, then it's really important that right from the top down, there is clear messaging to the public about balancing those risks and making sure that they've got the right information to make informed choices.
Okay, Professor Catherine Bennett, always appreciate your insights and expertise. Thank you so much.
Thank you, Girish.
All right, let's do a couple more videos. I'll stop interjecting so much so we can get through more of them.
My mother and my grandmother and my great-grandmother, my aunts, as far back as I can remember, have always...
And concerns that gripped the country. Let me tell you, 13 deaths have been reported in India so far, largely those with comorbidities, but one man died at the age of 40 today, and he had no comorbidities. There were no underlying health conditions. He was admitted to the hospital in a severe condition where he had acute respiratory illness, and 2 days into being...
This is what I mean. Not all infections are going to be mild. You just don't know. You just don't know. And that's, most people view this as, well, did it cause a hospitalization? Did it cause death? Oh, if not, then I'm okay. No, you can have mild and it causes the turbocancers and the dementia later down the road. I'm not even sure. Is it better to die early from SARS-CoV-2 or to die a slow death through turbocancer and dementia? Oh, by the way, the same thing can happen with the inoculation. So how do you solve this problem? Like I said, everyone is affected. It's just your risk curves are different based on luck, based on your health, based on the number of times you've been inoculated or the number of times that you've been infected. All these things are factors. No one is safe. If someone thinks that they'll be safe, this is not like polio, for example. Like with polio, it's very clear, all right? If you don't get the vaccine, there's a big chance that you could get it, all right? If you do get the vaccine, the chances of getting it are extremely rare. Now, I had a friend that was in junior high school that had polio. You know why? Because he wasn't vaccinated. All right? Very clear. This is different. This is a different situation where the pathogen and the inoculation can cause harm. Now, people would say, well, polio can cause harm too. Polio vaccine can cause harm. Well, that's true in rare cases, but when we're talking about SARS-CoV-2, there are pathophysiologies that are heavily linked to the inoculation, and pathophysiology issues that are heavily linked to the actual viral infection. All right. It's not so simple as to do or not to do. It's not that simple.
Hospital, he succumbed. I'm going to take you through all the details here. We're looking at 3 years later. As much as we thought COVID was done, COVID seems to be back in our lives. India is once again in the grip of a fresh wave. It's being fueled by a new and fast-spreading variant that has now shown up in the United States and across Asia. In the last 24 hours alone, India has reported 13 COVID deaths, the highest daily toll in nearly a year. Among them, a 40-year-old man from Chandigarh with no comorbidities who died just 2 days after being admitted with acute respiratory distress. In Chennai, in the last 24 hours, a 60-year-old man has died. He had multiple underlying conditions. He succumbed to COVID. In Maharashtra as well, today, a 67-year-old man from Dombivli who was unvaccinated, again, he had pre-existing health conditions, has passed away. Health officials, though, insist there's nothing to panic as yet. The warnings are loud and clear, though. COVID-positive patients must isolate. Masks are back. Hospitals are currently on alert. What's raising eyebrows, though, is the variant that's now seeing a spike. That's the NB181 strain, which is also spreading globally. In the United States, that it's being detected, health experts say, could be very risky for young children. First spotted among travelers in California, Virginia, and New York. In fact, the NB181 variant is now driving a fresh hospitalization surge, not just in the United States, in China, Hong Kong, of course, cases have been rampant there. They're the worst hit. Over 80 severe cases have been reported in just 4 weeks, 30 of them fatal. Most among them are seniors, though United States say many infants too have been infected. In India as well, we're looking at similar claims that several children have been infected. In Bengaluru, there have been cases of infants who've caught COVID-19. Now, let me take you through the symptoms. As you see there very clearly, the NB181 symptoms include persistent cough, sore throat, fever, body ache, fatigue. In fact, some patients also report difficulty in breathing and loss of appetite. While Hong Kong officials have downplayed the variant's severity, US, though, on the contrary, scientists disagree, saying that there is a spike in hospitalization as well with this very variant. The virologist Subhash Verma in the United States confirms that this one is the one spreading much faster than previous variants. So here's what's changed. Despite rising threats, the CDC, United States, has updated its guidance, saying that healthy children and pregnant women do not need COVID vaccinations anymore, but isolation masking is mandatory. Trump administration, on its part, is proposing to restrict annual boosters only to seniors and high-risk groups, basically saying that children with good immunity do not need it. So they've reworked on their guidelines, saying that vaccination for young children not really mandatory, but at the same time, for senior citizens, it's all the more imperative that they are vaccinated. This, of course, raises multiple questions here. Are public health agencies in India at this point really stepping up? We hope not to see what we saw the years gone by. Multiple waves of COVID. This, again, seems like deja vu. Just hope that we're prepared. Hospitals are getting up, but you and I are equally responsible. Isolate, wear your masks at public spaces.
Wearing a mask ain't going to stop this. Taking a booster is probably only going to accelerate it. And guess what? No matter what you do, you can't hide from it. And I've been saying this from day one. But if we shut down those laboratories, if those gain of function research laboratories weren't in existence, we wouldn't have this problem. Now, people would say, well, it was released in 2019 and we couldn't stop it. Well, most people were infected by Omicron, and that was in 2021, in about October. That was released. Now, people shut down those labs and protested and demanded accountability from the people that made it. And by then, people knew by 2021 who the main characters were. But Congress didn't do anything about it. And eventually Omicron was released. Omicron was not an emergent variant. It was released. It was released, right? So if there was more of a public outrage in 2021 or even in 2020, we probably wouldn't have this problem with the turbo cancers, or at least it's not as prevalent. All right. But mankind didn't want to do the right thing and shut down these labs. And now we have a problem that you can't put back in a box. You can't solve this problem. You can only mitigate the risks. You can't solve the problem. And I've been saying this for 5 years. Now, we're going to have ill wax and wane. And, there's going to be this endemic, phase, comes and goes. There'll be spikes in cases and deaths in some situations. But as this is happening, you further increase the risks of the turbo cancers and the dementia. There's no way out. There's no way out. You're trapped. And part of the reason is because we allowed our government to do this. Another part of the reason is that we're allowing the paradigm to take hold, and it's causing more harm. Got to push back. But again, even if you push back on the paradigm of inoculations, it still doesn't solve the problem with what was released. So you have to push back on big pharma, on the paradigm of inoculations and overboosting. But you also have to push back on the laboratories and everyone that was involved to prevent a further, a new variant or a new pathogen from being released, what I call the fourth or fifth cocktail. But if mankind doesn't stop it, it's only going to get worse. But people don't want to listen. People prefer to just live in their own echo chamber, try to believe something, or try to, just have cognitive dissonance and try to wish it away. It's not going to be wished away. This thing's going to be around for the rest of your life. It's never going to go away. It's only going to get worse. Because when you get older and your immune system isn't as robust as when you were younger, or you don't have the same neurological function as when you were younger, and you might contract SARS-CoV-2, and all of a sudden pushes you over the edge.
Look at her, the busy bee. She doesn't have time to build a bookcase, does she?
Scientists at Stanford have detected a new COVID variant that experts say is already evident in wastewater samples in California. And this comes as vaccine access could be changing. I'm Amadate.
And I'm Dan Ashley. Good evening. Thank you for joining us. ABC 7 News reporter Leslie Brinkley looks into what we can expect going into the summer and then the fall.
COVID-19 is still evolving, and scientists are keeping close tabs on NB.1.8.1, a substrain detected in China last month, and now it's circulating in the Bay Area.
It has been reported in Europe, and it's been reported here in the U.S. We've seen it here in our wastewater. We've seen it here in California in wastewater. So it's around.
Experts at the University of California at Berkeley say the good news is this strain does not appear to be more virulent, but it does look to be more contagious.
It appears to be able to attach to the receptor sites on our.
Now, there's different, if you've been paying attention, different people are saying different things. Some people in Asia are saying it's more virulent, right? And more contagious. Other people are saying the opposite. It's more contagious, but less virulent.
cells more avidly with greater ability, which may mean that it's more transmissible, which would not be good news.
COVID numbers have been low in 2025 so far, but
I think what's happening is it's more transmissible and then it's more infective. And the infectivity of the cell is increasing. And I think that also the actual spreading of it is increasing.
could change in the coming months.
Come the fall and next winter, respiratory season, if you will, we will see a resurgence, more people getting infected with the circulating variant, more people hospitalized, and more people dying.
I agree with that. And it's going to couple with potential more cases of bird flu. Don't forget bird flu. It's not a matter of if, it's a matter of when those mutations take hold in nature that leads to a jump to human transmission. It's a matter of when, not if.
That could be factored into decisions about an upcoming COVID booster, even as vaccine access is being restricted, with the Health and Human Services Secretary now removing the vaccine from the CDC's immunization schedule for pregnant women and healthy children.
We know that if you're vaccinated during pregnancy, those antibodies that mom develops pass through to the baby and protect the infants and the very young children.
Okay. Let's say they protect the infant. It stays there for about 6 months or so, or less. But the thing is that those antibodies, see, one of the problems with the inoculation is autoimmune problems or vascular problems. So you can lead to problems with vascular or autoimmune issues with children, and they won't manifest themselves until about 1 or 2 years after birth. Now, okay, so we have that issue that's potential, but not just that. You have miscarriages, increased miscarriages because of the vaccine, the inoculation. So I really don't take the perspective that inoculating a pregnant woman is the best thing for the neonate or the mother. But again, there is no safe haven. It's possible that the child does get infected by the pathogen or the mother during pregnancy. So again, you're painted into a corner. There's no way out. There's no good solution.
Up to about 6 months of age from COVID.
Yes.
So all of this protection is being lost by this decision.
I personally am going to get a booster. I recommend my friends and family get the booster.
I'm Leslie Brinkley, ABC 7 News.
The Silverado Trail Boss. And the suspension to make it
no.
Health and Human Services Secretary Robert F. Kennedy Jr. says he is removing the CDC's recommendation for children and healthy pregnant women to get the COVID-19 vaccine. And a new variant of the virus has made its way into the U.S. The strain is now being reported in at least 4 states, including California, Washington, Virginia, and the New York City area. Let's bring in Dr. William Schaffner. He's an infectious disease expert and professor of medicine at Vanderbilt University Medical Center. So, Doctor, I mentioned this new variant comes at a time when the FDA is also planning on limiting access to the COVID vaccine come the fall, demanding new trials. How significant is today's announcement about the removal of this recommendation for children and pregnant women?
Well, Lindsay, the removal of the recommendation for younger persons and pregnant women is a top-down recommendation. You know, normally we give recommendations to the CDC's Advisory Committee on Immunization Practices, and They then send that recommendation up through the CDC director to the secretary. And that system has worked very well for over 60 years. And so we're in a little bit of uncertain turf here about how recommendations are going to be made going into the future. Now, let me say quickly that the CDC's advisory committee is scheduled to meet in June. And actually, their discussions in their previous meeting looked to me as though they were moving in an entirely similar direction. So at the moment, I think the availability of vaccines for younger persons and for pregnant women, just as the COVID summer surge is about to begin, is a little bit uncertain about whether insurers will pay for it.
Let's talk about COVID summer surge, the possibility of. Is that because of this new variant, or is that because in summers past we've also seen an uptick in cases? And what can you tell us about this new variant?
Yeah, it's for several summers before, we've had a summer, midsummer, late summer surge in addition to the winter surge. It's like a two-hump camel that we have. This new variant appears to be a member of the Omicron family, just another cousin, if you will, to those Omicron variants that are going around. Does not appear to be more severe, is likely to be contagious, and the currently available vaccine is likely to continue to provide protection against severe disease. So that's very reassuring.
Okay, Dr. William Schaffner, thank you so much.
First of all, you got a lot of cross-reactivity with what the antibodies that the society has right now. But overboosting is going to weaken your immune system. And, you know, there's very little good research on safe and effectiveness of neonates and pregnant women, you know, in this situation. And, you know, there was quite a bit of research saying that termination of pregnancies were taking place because of vascular problems. So I don't trust it. I don't trust it. Don't trust it. Absolutely don't trust it.
Attention shoppers, for more browsing, go to Guardians.com. We've got a big story to tell.
Some say things never change. They're not builders.
Builders don't believe in talk. We believe in action. We don't just.
As 2025 unfolds, concerns about a potential COVID-19 resurgence have emerged, fueled by rising transmission rates in several U.S. states and the continued global circulation of the virus. While the acute phase of the pandemic has passed, COVID-19 remains a persistent public health challenge driven by seasonal patterns and the emergence of new variants. Recent data from the CDC reveals that as of December 2024, infections are increasing or likely increasing in 28 states, with only 3 states showing a decline. In many areas, the effective reproduction number is above 1, indicating heightened transmission.
Right. That was 4 months ago, so that's a little bit outdated video.
Just when we thought COVID-19 was firmly behind us, it's knocking again, this time with a new twist. From the southern states of India to the streets of Singapore, there's a subtle but steady rise in infections. So what is going on? This is
the thing that is worrying me, is it's with multiple countries within Asia. And it's already in the United States. Now, does this mean that we're going to see the huge waves like we saw in prior years during the COVID era? No, it's not going to be that bad. The thing is there's this pulsing. There's 2 pulses that are taking place. The pulsing of infection that will lead to IgG4s to be elevated, and that it's going to be immunosuppressive. Increases your risk of terminal cancers and increases your risk of dementia and cardiovascular issues. But then you also have another population that's going to be fearful, and they're going to take the booster, which will lead to increased risk of terminal cancer, dementia, and vascular disease. Like I said, there is no way out. mean, sit back and really think about this for a second. What path is safe? There is no safe path. It's dealing with uncertainty, dealing with risk assessment, dealing with probabilities. There is no right answer to this.
It's another blip or the beginning of a bigger wave. Well, a new subvariant NB 1.8.1 has just been detected in Tamil Nadu, and experts are watching it closely. So before panic sets in, let's take a closer look at what the numbers are saying and what science tells us and what precautions, if any, you need to take right now. Here's a comprehensive update on where things stand. This week, India's health ministry confirmed a new uptick in COVID-19 cases, mainly in Maharashtra, Karnataka, Tamil Nadu, and Kerala, with a new subvariant NB 1.8.1 detected in a sample from Tamil Nadu. Across the globe, several countries are also reporting new COVID-19.
And another thing that's very interesting is that as the war starts to ramp up between Pakistan and India, and the potential war between Taiwan and China, you're getting a surge of SARS-CoV-2 cases.
According to the
So the point I'm making is that there, that's part of the calculus. As people get sick, there may be, the potentiality of a ramp down in conflict, but there could be that chance of increased conflict to take advantage of your opponent being sick.
World Health Organization, Southeast Asia in particular, is seeing a noticeable rise. In Singapore, for example, cases rose from 11,100 to 14,200 in just 1 week. As of Tuesday evening, India recorded 1,010 active infections, where Kerala 43% of cases, Maharashtra with 21%, Delhi, Gujarat, Tamil Nadu ranging between 7 to 10%. Deaths have been reported recently in Maharashtra, Kerala, and Karnataka, but authorities say it's too early to confirm if these are COVID-related. While the outbreak appears geographically limited, only Kerala, Maharashtra, and Delhi have more than 100 active cases each. A clearer picture is expected in the coming weeks as testing ramps up for symptomatic individuals. No significant increase in hospitalizations has been reported. Those admitted mostly had underlying health conditions, suggesting that.
And this is the false hope, that people in the United States are going to notice. Hospitalizations aren't that bad. People aren't dying, but you're missing the point. The pulsing of an infection, natural infection, or the pulsing of the booster population is going to lead to further problems with dementia and turbo cancer.
Severe disease remain rare for now. Experts say periodic COVID-19 waves are now expected throughout the year, similar to the flu. Several reasons may be contributing: waning immunity from past infections or vaccines.
And the reason why, if someone goes, well, this is endemic now, and that, there's antibodies in the population, and this is just going to be more like just the flu kind of situation. Wrong. This has been honed through serial passage from multiple receptors. And as it goes through the pinball effect, where it's gaining affinity to other receptors, different pathologies are going to emerge. This is not influenza is, is relatively benign because it's not hitting all of these fine-tuned receptors through the serial passage. There was gains of function, not just on the ACE2 receptor. It was on multiple receptors that have multiple pathophysiologies. It's going to be a moving target for physicians, and they won't even know what hit them until lots of patients are coming in positive for SARS-CoV-2, but not showing, the normal manifestations. You're starting to see it now. They're perplexed on the turbo cancers. They're perplexed on the dementia increases. Now, I suspect that microplastics are contributing to the additional dementia cases, and that dementia would have started to take hold in these patients already. So you have the microplastics and the nanoplastics in brain tissue that's correlated to dementia, right? So we have microplastics in our different tissues. But when they did a study, they noticed that more microplastic increases led to elevated cases of dementia. All right. Well, you have a population that's getting these microplastics and nanoplastics in the brain. But when pulsed with boosters for SARS-CoV-2 or infected by SARS-CoV-2, it may accelerate the process because 75% of those cases that have brain dysfunction that are associated with SARS-CoV-2, 75% of those cases will lead to vascular dementia. But as you're accelerating, you have the microplastic environment slowly causing the dementia, accelerated by microbleeding or microclotting from SARS-CoV-2 or overboosting. And people don't pay attention. And that's a different type of pathophysiology compared to a pulmonary infection. It's a totally different branch of science in medicine. You know, it's a neurologist versus a pulmonologist. They don't even talk to each other. This is what I mean. There's going to be pathophysiologies that will emerge that will perplex the scientific community.
Emerging variants with higher transmissibility, seasonal trend in respiratory illness, reduced testing and surveillance, and greater exposure risk for high-risk groups. Globally, the WHO is tracking one variant of interest, JN1. 7 variants under monitoring include NB1.8 and LF7. JN1 and its descendant like NB1.8 now dominate sequencing data in some countries like Singapore, but there's no evidence that these cause more severe illness. In India, recent samples mostly show BA2 and JN1. No variant is currently labeled as of concern. To protect yourself and others, wear a mask in crowded places. Isolate at home if you have mild symptoms. Practice hand hygiene and distancing. Stay hydrated, monitor symptoms, and use meds for relief. Avoid antibiotics unless prescribed. Seek medical help if oxygen falls below 93%. You have severe cough or fever for more than 5 days. You struggle to breathe. High-risk individuals, including seniors, unvaccinated people, and those with conditions like diabetes, heart disease, or weakened immunity should be especially cautious. COVID-19 hasn't gone away, but we have come a long way in managing it. Stay alert, stay informed, and take the necessary precautions as we move through this next phase.
Network 18 decimates time.
Well, there's going to be more cases in the United States. It doesn't mean cause for panic, but it needs cause for vigilance. The next video that I do, pay attention to some of the ways to mitigate. All right? There's no magic bullet. If anyone says there's a magic bullet, they're wrong. There's no magic bullet, right? No matter if you took the inoculation or natural infection, there's no magic bullet to solve the problem. But you can reduce your risk factors. And when you reduce your risk factors through a certain protocol that I've been saying for 5 years, then you are better off. But what you got to do is just be vigilant. But you can't hide from this. It's not going to help you. Hiding from it is not going to help you. It'll eventually get you. And, believing the dogma in terms of, over inoculating is most likely going to exacerbate the problem. So please help support the work that I do by making sure you subscribe to all the channels that I have. I have 4 channels on YouTube, Brighteon, Bitchute, and Rumble. Subscribe to all those channels. Ask your social media to follow me. Who else is telling you the real deal, right? Unvarnished, right? You have these other celebrity docs. We'll just focus on one side of the issue and try to give you some hope, right? But there's really no hope. All you can do is really just mitigate the risks, and everyone is at a risk. But the thing is, you got these celebrity docs, they'll just focus on, well, there's a gigantic crowd out there that is anti-inoculation, right? And that's okay. It's you're right. But to assume that you're safe by having that stance, you're just wrong. You're just wrong. So pay attention. If you pay attention to me and you focus on the whole spectrum of the risks, then you have a better idea on how to navigate forward. But it's not easy. There's no simple path. And you got to live your life, not live underneath your bed, right? So please go to my website, the-studio-reykjavik.com, and help support the work by donating. All these videos I do are for free. I don't put anything behind a paywall. Some people put stuff behind a paywall, and that's how they accrete funds, but I put everything for free out there. Help support by donating. You can donate through Stripe, PayPal, or buy me a coffee. You can be a paid member to my Patreon channel. And that allows me to do all these videos for free. And take a look at the website and what I offer. If you pay attention to how to mitigate the risks, you will be better off. It's that simple, all right? But there's no magic bullet. It's about risk factors and luck, all right? So have a nice day. I'm going to do another video, and just pay attention to to the things that I have to say on this way to mitigate. So thank you for listening, and have a nice day. And don't panic, but just be aware. Be aware. Thank you for listening, and have a nice day.